Ulrich Scherer, and myself, we would like to welcome you to this WIN session with the name Bite Me, about bispecific T-cell engagers. And we're very happy that so many colleagues found their way this morning. And we don't want to waste time, and I would like to introduce you to Dr. Wolfgang Merkt, who is the medical director in the south of Germany in Bad Kreuznach and principal investigator, University of Heidelberg. And Wolfgang, we are very happy to have you here on stage and bringing us the latest news about bispecifics.
Dear chairs, thank you very much for the kind invitation to the auditory. It's a real honor to speak in such a huge auditory today. So my topic is BiTEs. I have some conflicts of interest, but they do not relate to the topic. And let me first give you an overview. Today, I will first introduce you to the topic of bispecific T-cell engagers, which are also called BiTEs, an incomplete B-cell depletion in tissues. And we know that plasma cells are spared. Those are the main producers of autoantibodies in many diseases. But also there are Fc receptor variants which affect the efficacy of the Fc part regarding the target, the effector cells, which are necessary for the B-cell depleting function of rituximab. And also there might be pathogenic B-cell repopulation. So we are on the search of better ways to deeper deplete B cells, and we learn a lot from hematology, because B-cell lymphomas, or in the field of B-cell lymphomas, there are many new developments. And nowadays, you distinguish based on the antigen how broad the B-cell depletion can be. We know that there are several surface antigens. Rituximab is binding to CD20, but there's also, for example, CD19, which is more broadly expressed on the different B-cell subsets. There's also BCMA, a rather plasma cell marker, or CD38, which we know from Blinatumomab. But there's also something that we call the depth of B-cell depletion, which means that B cells are more or less depleted also in tissues. So why all that? What is the aim? And I think this aim has been formulated for the first time when the first patients in rheumatology have been treated by CD19 targeting CAR T cells because of the great efficacy. And the efficacy in the first patients was so great that one could think that we now could reach something like an immune reset. Immune reset builds on the understanding of what is happening in rheumatic disease. So we have in our patients, very generally speaking, a genetic predisposition and then some form of immune dysregulation. Immune dysregulation on itself is not necessarily linked to symptoms, but an overt disease can happen if there are several triggers happening in addition. And what we currently, or what we've done in the past, when we used immunomodulatory therapies, we were successful in switching off symptoms, but we were not able to also eradicate the immune dysregulation. But this would be possible in immune reset. So the idea of immune reset is to really eradicate all this aberrant immune features like antibodies or also other immune cells that show alterations in the disease. So now, what is a BiTE? A bispecific T-cell engager molecule can look like this. So these autoantibodies are engineered in a way that we have one domain binding to CD3, which is a surface molecule on T cells, and we have one antigen binding domain which binds to a surface antigen on B cells. And these bispecific antibodies then could bridge B cells, which we want to kill, with the T cells. And this brings the two cells in very close proximity so that a so-called cytotoxic synapse can be formed, and that leads to the T cell activation in a way that they produce granzymes and perforin and release them into the direction of B cells, which are then killed. So the immunosuppressive effect is based on the killed B cell, but the T cell activation can also lead to side effects like the cytokine storm, because during killing they also produce cytokines. Nowadays, there are already several bispecific antibodies approved by the FDA in oncology. As you can see, the oldest one is Blinatumomab, CD19, CD3 BiTE, and the other BiTEs are quite new. I marked those with an arrow which have been used in rheumatology. So the BiTE formats can be different, and this makes the drugs also working in different manners. So the minimum is that we have 2 antigen binding domains, like in the FV-based formats, where we basically have only the very small antigen binding domains which are linked with a small linker. These molecules, for example, Blinatumomab, are extremely small, and this is why they have a very short half-life, because it's directly excreted by the kidney. So the half-life is around 2 hours, which makes it necessary that the drug is continuously infused 24 hours a day over several days. And it also makes it very accessible regarding the tissues. The BiTE could also be IgG-based. For example, Teclistamab, it's a whole antibody with an Fc part, and then the BCMA binding domain. BCMA is the molecule that is expressed on plasma cells, and it's used to treat multiple myeloma, and also CD3 for the T targeting. And because the plasma half-life of molecules like Blinatumomab is very small, there are now new combination type antibodies. For example, they could be linked with an Fc domain in order to enhance the half-life. So we have competitors nowadays. So we have the luxury of having different strategies to kill B cells. You may have heard about CAR T cells. This is the hot topic of the last years. Here you don't have to infuse an antibody. So the CAR T cell is a cell product where a receptor binding B cells is directly on the cell. BiTEs are antibodies that couple B cells with T cells. But I also would like to mention the more conventional monospecific, so-called monospecific antibodies that have been engineered to have a higher affinity to Fc receptors. Because in my understanding, an antibody has always 2 sides, and every antibody is a bispecific antibody because it binds on the antigen binding site, but also the Fc part can bind to Fc receptors. So these antibodies, such as Mosunetuzumab, EULAR or Inebilizumab, they function bispecifically because they bind on the one hand side B cells, but with the Fc part, they can bind to Fc receptor effector cells, such as natural killer cells. That means also that we should have a look on the effector cells when we treat patients in the future. For example, when we want to treat with BiTEs, we need T cells here in the tissues, but when we want to deplete B cells using Fc-enhanced monospecific antibodies, we might need the effector cells also in the tissues. And what I also wanted to mention is that in this scenario here, we have phase 3 trials, which we don't have regarding BiTEs or CAR T cells. So the medical evidence is much better for the third group. So second, I would now like to talk a little bit about efficacy. So the efficacy is nowadays based only on case reports and small case series, and also on the safety. And I will mainly talk about Teclistamab, the CD3 BCMA bispecific, Blinatumomab, the CD3 CD19 bispecific, and Mosunetuzumab, which is a CD3 CD20 bispecific. There has actually been a relatively new review. Relatively new means that it has been published in March, but the field is moving so quickly that already by now, it's not every study included here. But I wanted to show at least the safety profile, which has been summarized for all the bispecifics that have been applied in rheumatology. So in total, 80 patients have been reported, and I, for myself, had at least 3 learning points. So the learning point 1 was safety regarding the cytokine release syndrome, which happens in around 50% of the patients, but most of the CRSs are of a low grade 1 and 2, but CRS grade 3 can also happen in some patients. ICANS did not occur at all, those 80 patients. And finally, point 3, hypogammaglobulinemia can play a role, but this is most important in the patients that have been treated with Teclistamab. I would like to then talk about Teclistamab a little bit in more detail. So you may have come across this case report, which has been published already 2 years ago, so it's already quite old in the field. It's one of the first lupus patients. And as you can see here, the clinical efficacy was really huge. So this was a refractory patient having received multiple immunosuppressants. But after the treatment with Teclistamab, within 6 weeks, no symptoms were there anymore. And also the anti-dsDNA antibodies normalized within 6 weeks. The CL3 titer normalized within 6 weeks. So really promising data. There have also been reports on non-SLE patients treated with Teclistamab. This study here summarizes 10 patients. I concentrate a little bit on the safety profile because it's a little bit hard to show data on individual patients in a very condensed correspondence paper. But here it's confirmed that hypogammaglobulinemia is a problem in every single patient, and all patients had to receive IgG substitutions by IVIG. Infections are accordingly quite common despite IgG supplementation, but severe infections can be in most cases handled. So in this paper, I'd also like to show the supplementary because despite all success, we still have or can have refractory patients. So we had here one myositis patient who did not really respond. So orange is active disease and blue is response. And there have also been relapses in 1, 2, 3 patients. So 4 of 10 patients had refractory disease or relapses. And this is important when we think about immune reset. So in those patients, I think that was at least not for the rest of the life, maybe a short-term reset. There have been 2 very new publications in patients with immune thrombocytopenia. This is not rheumatology, but I think most of us know the diseases. And the clinical effect was quite impressive in 4 patients. In the first report, many pretreatments and normal thrombocytes have been observed afterwards. And importantly, and that's why I show the slide here, already after only 1 week, the autoantibodies against platelets have completely disappeared. And the second study I show because we here have also data on bone marrow biopsies. And as you can see here, after 40 days or 14 days, all plasma cells have gone. This is important because it shows us that the treatment schedules that they used really lead to a plasma cell depletion in tissues, which is actually the aim of the therapy. And they did what we usually do. The first 3 doses are so-called step-up doses, and then the highest dose is repeated at least once. And rheumatologists also do it in a similar way. There's also one report that investigated thrombocytopenia in a lupus patient. And here again, after Teclistamab induction therapy, there was a great response. In this paper was also reported a new potential side effect, and the patient responded really well regarding the lupus, and the patient was in remission afterwards, but she developed inflammatory bursitis, scleritis, and also an IBD-like gastrointestinal problem, which was then successfully treated by Bispecific. I would like to separate systemic sclerosis because the disease is a little bit more complex. We have autoimmune features, but also other features, and we have a really high medical need. And I would like to mention that also CAR T-cell therapies have been applied quite frequently in SSC patients because of the high medical need. But there were several limitations, and I think one limitation is that in contrast to lupus, where the autoantibodies disappear after CAR T-cells therapy really quickly, the SCL70 autoantibody, topoisomerase 1, did not disappear in every case. I show you some papers here. For example, after 6 months in the Erlangen group, SCL70 did not completely disappear, but there were also other reports using different types of CAR T cells. For example, here even a BCMA CD19 double targeting CAR NK cell did not lead to a complete serological remission. Our own patient showed a persistence of CD19 targeting 3rd generation CAR T cells. However, even in this patient, it took 15 months until the SCL70 autoantibodies finally became negative. So the response of the antibodies, the autoantibodies, can be different regarding lupus or other diseases. And there are, of course, further limitations, such as the production process, which is really complicated. It's really expensive. You need the chemotherapy for lymphodepletion and so on. So there's some reason to find alternatives. And for example, in this case study from Siegert et al. From Berlin, this is one of the first patients reported on Teclistamab in SCL70 positive SSC. And here we observed some sort of clinical response regarding the skin manifestations. The MRSS dropped within 6 months. Also, the lung seems to improve. And importantly, ANA became negative, and also the SCL70 antibody dropped significantly, but maybe not that fast as in lupus. So this is after almost or around 6 months. Maybe the tendency continues and SCL70 becomes negative. And again, it's very important to monitor IgG, because all patients that receive Teclistamab get very low IgG levels. We've done that in my own former position in Düsseldorf in a cohort with 5 patients having SSC. Our protocol was quite similar regarding the Teclistamab dosages as the studies I mentioned before. So we used the step-up dose and then 2 to 3 cycles of the high dose in addition. But then we did a maintenance therapy using rituximab. So the idea behind that was to first deplete all plasma cells and also the B cells which disappear after Teclistamab therapy, and then continue B cell depletion in order to avoid replenishment of autoimmune plasma cells. We were quite successful in reducing the autoantibody levels, and again we have the safety issue regarding the hypogammaglobulinemia. Regarding the clinical efficacy, we had some benefit regarding the skin. For example, the MRS dropped from 21 to 10 in the first patient, and this was seen in every patient, so around at least 1/3 of the MRSS dropped. Regarding the lungs, within the first 6 months, we had no major effects, I would say, but at least the FVC and lung function parameters were kind of stabilized. We also have to say that these patients were really severely sick. Some of them would not even qualify for CAR T-cell therapy because they were too sick. Especially the first patient had a long-standing disease, so here's a lot of fibrosis going on. Regarding safety, we observed CRS up to grade 3, and we also observed quite frequent infections. So I would like to sum up Teclistamab in rheumatology with these key points. It leads to a deep B cell depletion, including plasma cells, but also other B cell subsets. It is effective, and even in patients that have been refractory to rituximab, but one concern is, of course, the hypogammaglobulinemia. Let's switch to Blinatumomab. Blinatumomab is a very small bite with a very short half-life. And we also have a dosing challenge here. So I show you here on the left-hand side a table from how oncologists, hematologists use it. In the first week, 9 microgram are given per day over a 24 IV application, which is followed by another 21 weeks with a higher doses of 28 micrograms per day. And then it's a pause of 14 days, and then the whole thing continues again. So this is not really nice for the patients. The first report from Munich used lower doses. Blinatumomab was first given over 5 days, twice, I think once in a month, and then 2 other cycles with a higher dose were given with over 5 days and 10 days. And what we observed here is a rather short B cell depletion, because after each cycle, the B cells repopulated in blood, which degraded over time, but still after the last cycle, there was still some B cells. And in this patient, the skin fibrosis, that was an SSC patient, improved significantly. Another study from Erlangen investigated Blinatumomab in rheumatoid arthritis, which was in patients that were highly refractory to previous treatments. The dose was quite low, only the low dose over only 5 days, which was repeated once. And here again, B cells come back after the first cycle. The patients responded over time, but you can see after 6 weeks, there was also recovering disease activity, and also there was no serological complete remission regarding rheumatoid factor and CCP autoantibodies. But the study has also shown that depending on the patient, one might be successful to deplete B cells in the synovium, but not in every case. So maybe the dose was underdosed. And also the patients in the Langenau paper needed follow-up treatment by abatacept. So this was not a one-shot therapy, no real immune reset, I would say. In our own study, we included 5 patients with myositis. All patients had JO1 antibodies. Oh, sorry for that. The dose is shown here. So in the first 5 days, we used 9 micrograms per day, followed by 40 micrograms per day. The drug is quite expensive, I have to say. And afterwards, we followed up again with rituximab. And why did we do so? I would like to show in a little bit in more detail the first patient, because I think that was very educative. At least myself, I have learned a lot when we treated this patient. So it was a myositis patient, highly refractory to many pretreatments. And the last rituximab was applied 3 months before we started Blinatumomab. And despite this rituximab treatment, the CK levels were quite high. After Blinatumomab, which was really excellently tolerated, the CK drops until being normal. But then in the blood of the patient, the B cells repopulated, the JO1 antibodies raised again, and she suffered from a relapse. So apparently, when we believe what has been shown in the studies before, where the B cells usually come back very quickly, this was delayed, and I guess this was because of the effect of the rituximab, which took much longer than that of the Blinatumomab. So our conclusion was that we give another shot of Blinatumomab, another course, and then directly followed up with rituximab, and then continue rituximab every 3 months in order to allow for a continuous B cell depletion. And that was quite successful. The CK dropped and remained negative, and also the JO1 antibodies became negative over time. And we did that very similar in the other 5 patients. Sorry for the busy slides, but you can at least recognize that the CK levels then dropped to normal in every patient. Regarding the lungs, we have at least stable disease in these patients. However, it seems to be really important to continue B cell depletion, because if we don't, for example, here, if you have the CD19 levels in blood, the B cells would come back, and this happened in 3 patients, and those were also the patients where we see the rising autoantibodies again. And in the other patients that have continuous B cell depletion, JO1 antibodies dropped over time, slowly but surely. We had 1 patient that needed IVIG because of hypogammaglobulinemia in association with pneumonia. So again, we had very severely sick patients. 3 of 5 suffered from pneumonia after treatment. 2 of 5 had a CRS with grade 3. So Blinatumomab, we also had a look into the tissues, and Blinatumomab induced successful B cell depletion. I think most interesting is maybe patient 5, because he was on rituximab, and we still found B cells at baseline despite rituximab in the tissue, and the patient agreed to get another biopsy directly after the end of the Blinatumomab cycle, and there we found no B cells. So it seems that a short cycle could maybe even lead to a tissue depletion in our patients. And also the MHC class 1 levels were normalized afterwards. Another study investigating Blinatumomab in systemic sclerosis comes from France, which has been published, I think, 1 or 2 months ago. And this was a very interesting cohort of 5 SSC patients, because they had uniformly the anti-topoisomerase, anti-SCL70 antibody, the MRSSs, in 4 of 5 patients were quite high, and they all had interstitial lung disease, and they all had either tocilizumab or rituximab, so this was quite standard therapy according to the current guidelines. They administered 9 microgram per day over 7 days, and then 28 microgram Blinatumomab over another week, so the dose is not that bad. But they did it only once, and they used no follow-up treatment, no maintenance therapy. Regarding safety, there were 3 out of the 5 patients having grade 1 or 2 CRS, and there were no severe infections. The B cell depletion, I'm sorry for that, occurred instantly, but the B cells came back within a few weeks. And accordingly, ANA antibodies did not get negative. IgG levels dropped a little bit, but did not become negative, and also the SCL70 antibody did not get negative. So regarding serology, this single course in SSC was not that successful. However, clinical efficacy could be observed, but only short time, according to what has been seen in the blood on the autoantibody profile. So there was a drop after Blina, but that was really only a very short effect and maybe an increase of the lung volumes, but that's it. And importantly, 3 of the 5 patients then also needed a rescue therapy after a few weeks. So I think together we can summarize that Blinatumomab has a very short half-life. That is important because of the application, but also is associated with a very short B-cell depletion, but in tissues as well. The clinical response is there, but the question will be how often must we give Blinatumomab cycles? What should be the dose, or should we use a follow-up maintenance therapy? However, it was very good also in treating rituximab refractory patients, for example, in our myositis cohort. And together we have now 3 case series in RA, antisynthetase syndrome, SSC with 16 patients where follow-up treatments have been applied. So the last drug that I would report here is Mosunetuzumab. Mosunetuzumab is an IgG-based BiTE that binds to CD20, the good old CD20. As you may know, most of the CAR T-cell strategies in rheumatology or the other BiTEs do not concentrate on CD20, so CD20 seem to be a little bit outdated. On the other hand, we also have diseases where rituximab is really excellent, for example, in GPA. So I think this is still a very interesting antibody. And it has been improved for a B-cell lymphoma a few years ago. So actually we have treated a GPA patient in Düsseldorf with Mosunetuzumab. That patient was a little bit peculiar. She had no kidney involvement, but she had a retroorbital granuloma, and as you may know, this is a difficult to treat condition. Even rituximab is in many cases not sufficient, or you have to repeat it a couple of times. And this patient actually did not respond to rituximab in combination with high doses of prednisone. Also, the addition of avacopan did not help, so that after the initial therapy with rituximab, the colleague switched to cyclophosphamide. Under the treatment of prednisone, avacopan, post-rituximab, and cyclophosphamide, the patient responded and the granuloma regressed. However, after the 6th cycle, there was a reoccurring disease activity with fatigue, arthritis, skin disease, and also again orbital pressure and the sensation of diplopia, and also the blood pressure raised again. So there was a relapse directly after the 6th cycle, and this is a difficult situation. What to do then? Because we thought, well, DMARDs would maybe not help. We therefore continued cyclophosphamide in lower intervals, but that did not really help in the patient. And this clinical relapse was actually also associated with a relapse of reoccurring CD19 B cells in blood and a relapse regarding the PR3 autoantibody levels. So we were on the search at that time for a better alternative for rituximab, and at that time there have not been applied so many BiTEs, so that was really new at that point. And we first considered obinutuzumab. Obinutuzumab is a CD20 monospecific antibody, the FC part of which has been designed to have a higher affinity to NK cells. So antibody-dependent antibody-dependent cell cytotoxicity is enhanced, and that's something that we have actually found a few years ago in vitro in PBMCs from healthy donors, but also from GPA patients, that obinutuzumab leads to a stronger NK cell killing than rituximab. But we also found in prior studies that there are no NK cells in GPA granulomas, and this patient had a large granuloma. So we thought that maybe if rituximab failed, also obinutuzumab would fail because the effector cell is not present in the tissue in this patient. And we actually let the initial biopsy reanalyze from our patient. And again, we found no NK cells in the granuloma. However, we found abundant CD20 positive B cells and abundant CD3 T cells and also cytotoxic CD8 positive T cells. So, as I said, Mosunetuzumab is a bispecific antibody that binds to CD20 and CD3, which depletes B cells. So we thought Mosunetuzumab would maybe be a good hit. And that was actually the case. So the clinical response was really huge. The patient refused higher doses of prednisone. So we used Mosunetuzumab as a single therapy, monotherapy, without an increase of prednisone, and we were able to thus induce serological remission. The CD19 B cells were completely depleted afterwards, and also the BVAS new and persistent scores that raised before the treatment fell afterwards, and the patient was in a complete remission without any symptoms at all. And also the granuloma regressed, as you may see here. So this was before treatment. This was after the combination therapy, including cyclophosphamide, and well, the regression was very small, but one had at least a feeling that after Mosunetuzumab it was a little bit smaller again, but at least it did not increase further. So we have a complete and lasting serological and clinical efficacy, and the drug was really well tolerated. Regarding the safety profile, we observed no severe hypogammaglobulinemia, and also the vaccination titers stayed more or less stable. And what we also observed was the serological response, which we show here in comparison to rituximab. So we normalized to before treatment, which is 100%, and then we calculated, sorry for that, a theoretic decline curve of antibodies. So a normal antibody has a half-life of around 3 weeks in the body. And when you think of a normal decay curve, this would look like the gray one here, but obviously rituximab did not hit the antibody-producing cells, the PR3-producing cells. However, Mosunetuzumab, the decline curve was very similar to the normal IgG decay curve, which is a hint that the PR3 antibody production was effectively and completely stopped once we give the CD20 bite. So I'd like to sum up. There were several firsts regarding this patient. It was the first report on Mosunetuzumab outside oncology. It is the first use of a CD20 bispecific antibody in rheumatology, the first bite in GPA. And that is, I think, really important. We gave this drug not in the first time, but the follow-up dosages we gave in an outpatient setting. So regarding accessibility to a huge patient cohort, this is much easier than CAR T cells or the other bites, because this drug is actually known to have a very low risk of inducing cytokine release syndrome. By the way, the study will be presented regarding the follow-up data tomorrow in a session and in the very morning. There were no other published data on Mosunetuzumab, but last year on the EULAR there was a presentation of a subcutaneous application of Mosunetuzumab, so we infused it intravenously, but the pharma company has an interest to have an SC application, and there are at least some data of these 15 patients in the dose finding study. So with this, I would like to go to the discussion of the findings. So I think there is overall a great efficacy, but we really have to learn how to handle these drugs and which patients should get which drug. Importantly, we also have, well, this is the reality which we have to accept, so there might be relapsing disease courses in BiTE treatments. Despite all successes, and this has been reported both for Blinatumomab and Teclistamab. For Mosunetuzumab, this is maybe too early, and also CAR T cells can be followed by relapses. What we should not forget is the effector cell. I think I mentioned this. I think it would be very interesting to get histologies before we start treating patients, to have a look not only on the antigens and the pathology, but also on potential target cells. And then we could maybe in the future make better decisions regarding CAR T cells, BiTEs, or monospecific, so-called monospecific antibodies in the future. What we should also not forget is the network. This is maybe a speculation or a discussion. I made this slide yesterday with the help of ChatGPT, so not all the links are maybe perfect, but what I would like to indicate here is that in active disease, we have a network problem. We do not have just one cell type, the B cell, which is aberrant, but the whole thing, the whole network is disturbed, including Fc receptor bearing cells, also stromal cells like fibroblasts, osteoclasts, macrophages, monocytes, and so on. We also have, next to the antibodies, we can measure immune complexes in our patients. So if we then deplete B cells only over a short time, the question is, what happens to the B cells that are re-established, that reoccur? If the network is still completely active, there are many positive activating signals from the network coming to the B cells. So my guess would be if the B cell depletion is only very short term, there might be a reactivation of B cells directly afterwards. So what we should aim at is maybe a little longer B cell depletion so that the rest of the network also gets time to recover. And once also the Fc receptor bearing cells are not activated anymore, the fibroblasts have been deactivated and so on, I think the likelihood that the whole disease restarts again might be lower. So I think timing is one of the important questions. Timing also includes whether we need or need not follow-up treatment. Importantly, we should not forget about the stroma. Why that? So I would like to show you here on the left-hand side the patient that we have treated back in Heidelberg a few years ago. That was one of the first cases actually treated with CAR T cells. SSC patient, female, where we actually induced immune reset. The antibodies after 50 months were completely negative, SCL70 was that. And we also had a really great response on the interstitial lung disease. But what I want to show here is we used FAPI PET-CT to directly label in human the fibroblast activation, and we then could calculate the area with activated fibroblasts in the lungs, which really nicely declines by -58% after 2 years. But it's not 100%. And I think the aim should be, when we want to also heal systemic sclerosis, if that is possible, then we would maybe need to get a 0% activation of fibroblasts. And also in the patients that we have treated in our study that I presented today with Teclistamab, the plasma cell depleting BiTE, we had a serological remission, but the fibrosis indices of the lungs at the follow-up time point at 6 months was maybe slightly reduced, but it means that the true fibrotic areas can maybe not be treated, and that means that we could not reach something like a healing or so in SSC. And I think at that point, this is again speculation, but there are some basic immunology data on that. So I think we have 2 phases, and this is nicely reviewed here by Weisenbeck et al. We have the trigger of fibrosis in the lungs on the one hand side, and this could be autoimmunity, but also other triggers. And these triggers lead at the end to chronic inflammation and to chronic fibroblast activation. But there is the second time point. Once the fibroblasts are activated and have accumulated, there is this self-perpetuating fibrosis in the sense of a vicious circle, and those fibroblasts activate themselves. So even if we get rid of the initial trigger, we might need to also break this vicious circle and fibroblast level. So hypothetically, if we want to target as a CILD, we need to once stop autoimmunity, maybe using a BiTE or CAR T cells, but we also need to break the fibrotic vicious circle, and we could do this by killing fibroblasts. And I would only briefly show this basic research paper. I'm very proud of that, actually. It has emerged only very recently. So here we established a new strategies that is, we call it NK cell immunotherapy, because we use a checkpoint blocker that activates NK cells in a way that they more efficiently kill fibrotic fibroblast subsets. It's a checkpoint principle like we know in oncology. So this NKG2A is an inhibitory receptor, and we know that persistent profibrotic senescent fibroblasts, they upregulate ligand. But when we deblock this inhibitory axis, we have more killing of senescent fibroblasts and clearance also in mouse models and so on. So with that, actually there's an interesting poster that formulates a similar idea. They say that we should maybe use BiTEs or CAR T cells as an induction therapy before fibrosis occurs, because once fibrosis has occurred, I think we know that from clinical experience, it's maybe too late. So there is something like a B-cell universe. We have talked about the depth and the breadth of of deep B-cell depletion, but also timing matters. And we have to put that into context. We have fibrosis diseases like SSC. We have also non-autoimmune features that need to be targeted. And with that, I would like to briefly summarize. So there are emerging case studies and series that enhance the accessibility of deep B-cell depletion on BiTEs. Efficacy is there, especially also in patients that are refractory to rituximab. So far, mainly Teclistamab, Blinatumomab have been investigated, but also first reports of Mosunetuzumab. The safety, we have CRS, but no ICANS, but in Teclistamab patients, hypogammaglobulinemia plays a role. The treatment schedules are not quite clear, especially in the Blinatumomab case, maybe underdosed. And there are few reports now also reporting induction therapy, induction maintenance approaches, and regarding the discussion, the deep B-cell depletion, timing is maybe also important. There are competitors next to CAR T-cell and BiTEs, namely the newer drugs, newer monospecific antibodies, and in autoimmune fibrosis, immune reset, in my mind, does not mean healing. Research agenda is we need prospective trials, of course, we need better biomarkers, we need more experiences with combination therapies, safety can be an issue, and we need to better understand the stroma role. And with that, I'm looking forward to your questions, and thank you very much for your attention.
Thank you very much, Wolfgang, for this beautiful overview and for sharing many of your own experiences in using these novel molecules. I see that there's a question already here in the front, please.
Yeah, thank you so much. Samuel Bitoun from Paris-Saclay University. I'm really interested in how your study published in Nature Medicine recently, where you combine rituximab after blinatumomab, looks like it resets the sensitivity to rituximab. Did you look at anti-drug antibody? Did you deplete with blinatumomab, then allowing resensitization to rituximab? And could this be the reason why rituximab started to work again, as it wasn't working in the beginning?
Thank you very much for the question. Very interesting thought. Unluckily, the answer is no. We haven't measured anti-drug antibodies against rituximab, but I really like the idea. We should do that in the future.
Thank you.
We have another question here in the front.
Thank you very much, Katarina Hadjidinisio from Stockholm. What would be your recommendation regarding refractory seronegative patients, considering that we cannot always measure certain autoantibodies, especially in clinical routine, and we cannot always take tissues in order to look for presence of B cells?
So if I understand correctly, your question is seronegative patients and whether we should then try deep B-cell depletion. I have no experience, to admit, so I would be very careful because I think there are several points to consider before you give an experimental drug to a patient, and in this case, I would consider an autoantibody being a prerequisite.
One more question.
Yeah, frankly, from Wuxi Aptec, great talk. So my question is, because you said like assess histology, anti-CD20, Mosunetuzumab show great efficacy, right? So why we just use bispecific 19 and 20 plus instead to assess the histology of the patient? My question number two is like BCMA, like TCE, right? Why that cause like hyperbeta-globinaemia, not other TCEs? The incidence very high. Yeah.
I think regarding the second question, why BCMA targeting BiTEs induce hypogammaglobulinemia and not the other ones. So also the other ones can induce hypogammaglobulinemia, but not so frequently.
Yeah.
First and second, because it targets the plasma cells. And I think this proves again in patients that the main producers of antibodies are plasma cells, long-lived plasma cells, which are not targeted by CD20 and not so often by CD19.
Yeah, thank you very much.
Oh, okay, we have time for one very short more question, and then we are already at the end.
So my question is on the clinical trials which you presented, was there any deliberate tapering of steroids to make sure that the T cells are functional and are able to act?
Thank you for your question. I actually haven't mentioned that. First, these were not clinical trials. Those were just experimental therapies in individual patients. I think this is important from an ethical point of view. Yes, in our teams, we always reduce steroids to a low dose if possible. And afterwards, in all the patients that I have presented, the steroids were either stable at 5 milligrams or reduced.
Okay.
afterwards.
Okay, thank
okay.
you.
Yeah, thank you very much. It is a hot topic, but we have to finish due to time. Please be aware, you saw it in the program, that directly now in this room we will have a hot session. Thank you very much, Wolfgang, again. And this hot session is on immune-related adverse events following checkpoint blocker therapy. Thank you.